Welcome to this explainer on modern clinical microbiology. If you're a clinical medical trainee just stepping onto the wards, well, this is built exactly for you. We're going to bridge that tricky gap between textbook microbiology and the actual bedside reality, zooming right in on the syndromic approach to diagnosis. Let's get into it.
Let's be totally honest here. That traditional bug-drug matching game you learned in your early years, it's completely overwhelming, right? You memorize these massive lists of taxonomy, shapes, stains, but that just doesn't reflect how patients actually present at the bedside. I mean, patients don't walk in wearing a name tag that says, "Hey, I have a gram-negative bacillus." No, they walk in with a fever, a nasty cough, or a painful ulcer.
So today, we're exploring a competency-based syndromic roadmap. We'll be hitting 4 key stops: a new clinical paradigm, targeted diagnostics, mastering infection control, and antimicrobial stewardship strategies. All right, Section 1, a new clinical paradigm. Let's look at how clinical microbiology has fundamentally evolved.
We're shifting away from that age-old, lab-limited attitude, the one obsessing over biological taxonomy, and moving toward a patient-centric syndromic approach. This completely aligns with the realities of modern, competency-based medical education. You're being trained to look at the infective syndrome and the clinical presentation first, because frankly, that's exactly what you'll be treating on the hospital floor.
To put that into perspective, organisms are now categorized by the primary organs they infect and manifest in, not just how they're transmitted. Take HIV, for example. It's sexually transmitted, sure, but it's classified as a bloodstream infection because it actually has no genital manifestations. Or think about enteric fever from Salmonella typhi. It's transmitted via the GI tract, but its major manifestations are extraintestinal, so boom, it sits right in the bloodstream category. And anthrax? That's skin and soft tissue rather than just zoonotic. It literally reframes how you think about disease. Building your clinical reasoning means grouping diseases into syndromes, like genital ulcerative diseases, so you can instantly differentiate etiologies right at the bedside. If a patient presents with a genital ulcer, you don't just run through a random mental list of bugs. You use clinical markers. Is the ulcer painful? Is there induration? What does the lymphadenopathy feel like? This lets you differentiate between syphilis, chancroid, or genital herpes right there in the exam room. It's like a giant puzzle, and you're just looking for the right pieces based on the syndrome.
Section 2. Targeted diagnostics. Now that we're thinking syndromically, let's see how this mindset actually directs our testing.
Modern hospital infrastructure is really stepping up to support this rapid clinical workflow. Gone are the days of waiting up to 5 agonizing days for conventional cultures. Automated culture systems dramatically slash turnaround time down to just 24 to 48 hours. This is an absolute game changer for initiating pathogen-directed therapy.
And it gives you way more than just fast cultures. It gives you rapid, actionable data right on the wards. You've got automated ID and sensitivity testing at your fingertips. You can gauge infection severity using fast biomarkers like procalcitonin and CRP. And this is the cool part. Syndromic multiplex PCRs, like the film array, let you test a single specimen for dozens of common agents all at once, giving you results in about an hour. Literally 1 hour.
But despite all this amazing sci-fi technology, never ever forget the golden rule, the culture of cultures. Antibiotics should always be started only after site-specific specimens are collected. Actually, let me repeat that for emphasis. Collect the specimen first. If you panic and give the patient antibiotics before drawing blood or taking a swab, you risk false negative cultures. You basically blind the lab, and you end up committing your patient to prolonged broad-spectrum blind therapy.
Section 3. Mastering infection control. Because accurate diagnoses naturally leads to protecting the entire hospital ecosystem.
As a trainee, you are on the absolute front lines of preventing healthcare-associated infections, or HAIs. By definition, these are infections acquired in the hospital, meaning they definitely weren't present or incubating when the patient walked in, and the symptoms show up at least 48 hours post-admission. They usually originate from a patient's own endogenous flora during invasive procedures, or from exogenous hospital environments. Your daily vigilance directly impacts the prevention of the 4 most heavily surveilled infections in any hospital: catheter-associated UTIs, catheter-related bloodstream infections, ventilator-associated pneumonia, and surgical site infections. Notice a theme here? Yep, they are all tied to medical devices or interventions.
So how do these bugs actually get to these vulnerable patient sites? Well, mostly through us. Since the contaminated hands of healthcare workers are the main source of transmission for these multi-drug resistant organisms,
Strict adherence to hand hygiene is absolutely non-negotiable. It's literally the single most effective method for infection prevention and control. No exceptions. Beyond standard precautions, which apply to every single patient, every time, you've got to know exactly when to step up to specific transmission-based precautions based on the suspected clinical syndrome. Patient has infectious diarrhea? Move to contact precautions. Suspect influenza? Droplet precautions. And for airborne threats like TB, you must use an airborne infection isolation room and snap on that N95 respirator.
Oh, and remember this absolutely crucial point. Say no to hanging mask syndrome. A mask is meant to protect your respiratory tract from infection. Resting it on your chin or letting it dangle around your neck, that just turns the inside of the mask into a vehicle to acquire and spread infections from your contaminated scrubs straight to your nose and mouth. When you take it off, take the whole shebang off completely. Section 4, Antimicrobial Stewardship Strategies. This brings diagnostics and infection control together into your daily clinical practice.
Stewardship is not just some hospital committee's job. It's your direct clinical responsibility at the bedside. The CDC defines it as using the right agent for the right patient at the right time with the right dose, route, and frequency, causing the least harm. This is exactly how we combat the terrifying rise of multi-drug-resistant organisms. True stewardship means knowing when not to prescribe. Patient has diarrhea? Oral rehydration is the mainstay of treatment, not antibiotics, because most cases are viral. Same goes for upper respiratory tract infections. You have to stop and think, could this be viral? Could it be a parasite like malaria? Could it be dengue? Rational prescribing means protecting our antibiotic arsenal by only breaking it out when a bacterial target is highly suspected or confirmed.
When you do prescribe, you have to strategically choose between two approaches. For a clinically stable patient, we use an escalation strategy. Start with a narrow-spectrum antibiotic and escalate to a broader one only if the lab reports resistance. But if a patient is crashing in the ICU with sepsis, you use a de-escalation strategy. Hit them hard and early with broad-spectrum empirical therapy to save their life, and then, and this is key, de-escalate to a narrow-spectrum antibiotic the exact moment the lab shows the bug is susceptible.
Always let the microbiology lab guide your targeted therapy. They'll provide minimum inhibitory concentrations, or MICs, and this requires absolute precision. For instance, guidelines suggest avoiding vancomycin for Staph aureus infections if the MIC is greater than 1 microgram per milliliter. Paying attention to these tiny thresholds, that's what separates an average trainee from an excellent clinician.
Transitioning from the textbook to the wards is a massive leap. It's challenging, and you will make mistakes. But like Winston Churchill noted, a quote aptly included in the dedication of our source material, success is not final, failure is not fatal. It is the courage to continue that counts. Continuous learning, right at the bedside, is going to make you a formidable physician. So I'll leave you with this clinical challenge for your next shift. Stop just matching bugs to drugs in your head. Look at the patient, start actively treating the syndromic presentation right in front of you, use the lab wisely, and practice relentless infection control. How will you apply this patient-centric mindset to the very next patient you see on ward rounds? Think about it. Thanks for joining me on this explainer, and I'll catch you next time.